and learn more about the IVP core competency number 1, the ability to describe and explain injury and/or violence as a major social and health problem, and core competency number 2, the ability to access, interpret, use, and present injury and/or violence data. This is the second webinar in our 4-part series of applying the public health approach to recreational boating injury prevention. The purpose of these webinars is to provide a first step in equipping NASBLA members and partners with resources to take a public health approach to their work. More detail about the remaining 2 webinars and how to register for them will be shared at the end of the presentation. Before we begin, a few housekeeping notes. With audio mode, while our presenters are speaking, please keep your phones on mute, and we will also have all participants muted during the presentation. Questions. To allow our partners to share their information and insight with us with little interruption, we will save questions for the end. You will be able to submit questions throughout the presentations by using the chat box in the webinar control panel to the right of your screen. Evaluation. Lastly, following today's session, you will receive an email with a link to an online evaluation. Your comments and suggestions are very important to us as we review and plan our events. So please take a few minutes to complete this evaluation. I will now introduce our speakers for today. Our first speaker is Alan Della Pena, Branch Head of the Injury and Violence Prevention Branch of the North Carolina Division of Public Health. Alan has been in his role as Branch Head of the IVP branch since 2010. Prior to that, he spent 27 years as a commissioned officer in the U.S. Public Health Service, assigned to the Indian Health Service, working in South Dakota, Arizona, and Maryland. He has been a leader throughout his career and has demonstrated vision for injury prevention in his position in North Carolina. Our second speaker is Lieutenant Seth Wagner, Assistant Boating Safety Coordinator with the Florida Fish and Wildlife Conservation Commission. Seth began his career in law enforcement with FWC in 2002. As an officer with FWC, part of his job duties was enforcement of boating safety rules and regulations. In 2012, Seth was promoted to lieutenant in the boating and waterways section of FWC. His primary duties included reviewing all boating accident reports that occur in Florida and to enter that data into the USCG's Boating Accident Report Database, or BARD. He also became a member of NASBLA's Engineering Research and Analysis Committee. Seth is responsible for creating an annual boating accident statistical report for his state and providing statistical data to his multiple sections within FWC and other agencies for improving boating safety. That information is used for enforcement activities, education, and outreach materials and content, and for local municipalities for consideration on managing local waterways. Please note, as we start this presentation, that you are able to download a handout, a resource for you in the webinar control panel. Without further ado, I'd like to turn this presentation over to Alan Della Pena.
Thank you. We got controls over. Yeah. We were doing a little practice session, so I'm still getting used to the timing for the slide advance. Just give me a moment. Okay, I think we're getting there. Just give me a moment. Well, I see that the cursor's moving for me, but the slide isn't advancing yet.
Alan, do you want to try hovering in the left-hand corner of the slide? Bottom left, sorry. There you go.
Oh, and do
and
that.
then just click advance.
Put that way. Okay, thank you.
No problem.
Well, no webinar is complete without a little bit of technical challenges to get through in this modern age of ours. So thank you so much. So again, I'm Alan Della Penna. I head the Injury and Violence Prevention Branch at the North Carolina Division of Public Health. And I like to put out a little bit of qualifier up front. I'm not a boating safety expert. I haven't worked a lot in that arena in my career, though during my Indian Health Service time, I interacted with the folks in Alaska quite a bit. And I know that North Carolina has adopted the Loaner Board program and so forth. I think my role on this webinar is more as an injury prevention person. And my goal is to kind of give it a little bit of overview of the way injury prevention looks at an issue, how we organize our data, in more of a big picture perspective where we fit in. I look at across the span of my career. I'm over 30 years doing this now, and I look at injury prevention like public health as kind of a system of thought, a way to think about a disease or a health condition, in this case an injury in a population, and then how to organize things to give the best chance of reducing the injury. And I always also look at the work as teamwork. It's kind of tough to do this in isolation. It's always better to join with partners, and I've found that partners working on an issue, the more diversity of thought that they can get and the more different opinions and skills and expertise, the better the results are. So, of course, I'm a little biased, and I think an injury prevention perspective helps think through an issue real well. I never try to pose that I'm going to offer opinions that the experts in the subject are best suited to do, because that's not where my training is. And the final thing I'll say at the introduction is, public health looks at the impact of an issue across the population. How it impacts an individual may vary. We look at how a whole population, whether it's a state, a county, or the users of a lake or a body of water, what's the experience that's going on with them in aggregate or across the population. So just a little bit about injury prevention, because it may be a little bit newer field for some of the folks on the call, and because it's within the body of public health. At the end of the last century, which I'm still having trouble saying the 20th century is the last century, great advancements in public health were made. Well, the public health experts in the country got together and they looked back and said, well, what were the greatest accomplishments in public health in the 20th century? And an injury topic was number 2, motor vehicle safety. As the rise in motor vehicles came up, the great advancements in safety. And I like to kind of say that from the perspective of the concepts of an injury prevention field aren't new. Sometimes when you've addressed a topic, your impact it may not be visible. So I like to kind of show that our world is surrounded by an injury prevention approach addressing a hazard in our life that is no longer a great hazard because we've addressed it through injury, whether it's child passenger seats for cars or PFDs for boats. We don't really approach it that we're going to eliminate the activity. Let's just identify how we can reduce the injury in the activity and allow folks to live a safe, productive, happy life, pursue the things in life that bring them joy, and reduce the hazard of death and disability while they're doing that. So, other examples, motorcycle helmets, child-proof packaging for medication, smoke alarms in homes. And the modern vehicle in America is just a marvel of engineering that's reduced so many of the hazards. And now as we move towards autonomous driving, if that dream ever comes to play, we're going to see even greater reductions on the motor vehicle side of the world. So this body of work is a lot of different folks working in injury prevention capacity over probably the past 60, 70 years or so. I also like to point out, some fields, injury is divided in many different organizations and many different disciplines, and this is just an example of showing how far back some of the organizations go and how diverse they are. From the Poison Control System, Safe Kids, Safe States is out there now, Consumer Product Safety Commission, and one of the last agencies to get into the injury prevention game, CDC, back in the early 90s. So often I find myself in a situation of working in injury where we're all talking about the same topic, but we're using different terminology because we are coming at it from a different discipline. And I'm always trying to be cognizant I've got to spend a little bit of time to learn the language of the discipline that's working on the particular injury issue at hand. So now let's talk a little bit about how injury looks at the issue. I think these are a couple points I'll cover in the next slide or two that helps differentiate the point of view and the perspective of injury. And injury has a real particular perspective that, so we kind of start out, what is an injury? And the classical definition is an injury is the physical damage that results when the human body is suddenly subjected to energy, and I'll emphasize the energy component. Energy in amounts that exceed the threshold of the physiological tolerance, or from the lack of a vital element. And in drowning the cases, the vital element would be oxygen. But it could be environmental heat, very cold weather, very hot weather. So the classical definition of injury is the interaction of energy upon the human body. The greater the energy, the greater the injury. Reduce the energy, reduce the injury. So a piece of lead coming out of the bullet of a gun is high energy impact. Much less for, say, a BB. A car, different methods of transportation. The real challenge is the higher the speed, the higher the injury. And I'm sure the folks in the boating world will see as newer, faster boats get on the market, you see just different methods of injury. So that's the first basic concept. This is, I put up the link. I pulled this definition from a basic Wikipedia site, but there's lots of this out there for those that are interested in getting this perspective and understanding it a little bit better. So a lot of the injury field is the art or the skill of what's the energy you're looking at. Kinetic energy, which is a vehicle in motion, mechanical injury, which you see in a factory floor or some other device, chemical energy, which is a poisoning, thermal energy, which is heat. So just that perspective. There's another great field out there that does really wonderful work, and our field kind of broke off from that a long time ago, and it's an accident prevention field. And I like to point out that there is a difference in focus of focusing on accident prevention or injury prevention. And the goal of injury is to reduce the physical damage. You may not be able to prevent the activity, and accident prevention is a little bit more on the activity, but you can reduce the damage an individual might sustain through that activity, whereas a focus on accident can kind of get the population to avoid the event causing the injury. It's a slightly different focus. So we don't focus as much on the quote-unquote accident. We spend more time on the mechanism of injury. It's a lot harder to change every member of society to avoid all hazards than to study the hazard and try to reduce its impact on human beings. And the final point I'll make on the injury, what is injury all about? This is a phrase kind of early in the injury prevention days. It's a mantra of a lot of injury folks. Take it with a grain of salt. I'm not so classically literal on it, but the phrase is injuries aren't accidents. And the way a public health person looks at this is injuries are predictable and preventable events. Accidents are often looked at as acts of God, an act of nature, an unavoidable event. And we approach injury that we can study injury through epidemiology, through the use of data, identify the trends and patterns that are going on, and try to drill in and identify a way to reduce the burden or prevent the injury from occurring. Sometimes the activity of life continues on, but the severity of the injury can be diminished. So I'm going to, my segue here is to talk a little bit about how public health broadly and injury specifically applies epidemiology in how we look at the options available to us. So public health looks at the multi-causal perspective. It's a foundation of public health in injury. It's the combination of factors that result in the disease, and by studying the interaction, we can find their weakness, and as we often say, break the chain of infection or break the chain of causation so we can prevent damage without maybe necessarily stopping an event from occurring. And I'll give several examples in that way. By looking at this causal event or multi-causal approach, it offers more options in changing the person than just through education. And we can change behavior beyond just educating the individual. And I hope through a couple of examples you can see what I'm referring to. So this is the multi-causal model, or the epi triangle. We see this in other fields. Highway safety uses this. But the foundation of this multi-causal approach is agent, host, and environment. So agent in the case of agent would be what causes a disease. So in a bacterial disease, it would be the microorganism. The host is the individual that gets sick or gets injured. And then in injury, the environment is where the event happens. And I'll give a couple other examples of how we in injury kind of operationalize this thought. And these are examples I pulled off the internet. So if you get so inspired to think about this a little bit more, you can just put in an internet search, epi triangle or causal model, and you'll see many, many examples, because pretty much everybody in public health, whether you're approaching communicable disease or injury or cancer or other health conditions, we look at this causal model, because if we can't change the individual, maybe we can change the environment, or maybe we can change the agent that's going on. So this is a couple other examples from a disease. So, what public health often does is maybe we can change the agent causing disease. In the history of the world, only one disease has ever been eradicated, and that's smallpox. So most of the great efforts in disease prevention has focused on changing the environment or changing the individual. And where changing the individual is, I just got my flu shot this week. I'm hoping to build up my resistance so that flu virus won't attack me. But we also do environmental changes. I wash my hands, and during flu season, I don't cover my mouth with my hands. I use a Kleenex and all that kind of stuff. So we're steeped in this environmental approach, provide hand sanitation to prevent diseases and so forth. So I have another model that drills in a little bit deeper on how public health folks think of this interaction, because I used that term earlier, break the chain of infection. So all you have to do is, let me rephrase that. What public health tries to do is, if you can break the interaction between the host and environment, or between the biological agent in the environment, whatever leg of this triangle you break, you're not going to have a disease or an injury occur out there. So examples I mentioned earlier, in a biological agent, it would be eradicate the thing that causes the disease or genetically modify it. And there's tremendous efforts in cancer right now that are trying to do genetic modification. For the environment, we try to improve housing. We try to improve sanitation, water supply, and preventive services. And in host intervention, have robust treatment available, immunization, good nutrition is some of the examples that are out there. So now we'll go a step a little bit closer from a biological disease model to an injury prevention model. Injury is really fortunate that we have a couple, I say thinking tools, brainstorming tools, conceptual models that we utilize that really help us think through the different options. This is called the Haddon Matrix, and I think an example of that is available. On this one, you can see it's from a classic article by Bill Haddon in 1970 called On the Escape of Tigers, and it really helps think through this idea of multiple choices and multiple opportunities for intervention. What the Haddon model does is take the epi triangle and adds the dimension of time, and I call it the prevention spectrum. Before the event happens, during the event and post-event. So, of course, in a motor vehicle example, because this is sometimes difficult to think through. Well, before the event, did your car have or were seatbelt laws required? Was law enforcement out there enforcing the laws? During the event, did you have an airbag available? Because you might have gotten a crash and the airbag could save your life. Post-event is, did you have EMS services that could get you to care within the golden hour? Did you get to a trauma center that is up to speed in training? That's the example of that spectrum, and I'll give a couple other examples in a moment. As I said, this is called the Haddon Matrix, and I readily acknowledge that this isn't for everybody. It's best to be utilized in a coalition or a team environment with somebody who's familiar with using the Haddon Matrix, because I've found many, many times that it can be an exercise in frustration if you're really skilled in one area, but it's not used to thinking pre-crash or pre-event or post-event. So and it's also easier to use if you're looking at data for a specific location versus national data or statewide data. Because, I mean, the reality is injuries happen at a location, and it's harder to conceptualize changes that can happen at a location if you're not looking that closely in at it. So the other thing that I got my sequence out of whack here. So the last thing I like to point out about the Haddon Matrix, and I'll have an example next to just use this in boating safety, is injury has added a third or fourth dimension, and that's the social environment. And I'll give a couple of examples of this, but many of the things that are needed to reduce the injury hazard fall within the policy realm. So you're changing the environment, but you're changing how a product is sold or the requirement of a safety feature to be added. So the social dynamic, you probably are going to have a hard time changing a body of water, but you might be able to change the policies of how individuals interact with that body of water and maybe restrict certain areas. That's just a couple examples, the social environments. That I guess a couple down the road, I've got the example from boating safety. So this covers that time dimension. Bill Haddon, I didn't mention him earlier. I mentioned the Haddon Matrix. Bill Haddon was an emergency doctor out of World War II that in the 50s and 60s really refined these models. He was the first head of what became the National Highway Traffic Safety Administration during that great era of improving highway safety. And he ended his career as the head of the Insurance Institute of Highway Safety. And a lot of the folks that worked for Haddon kind of entered the injury field. So we've had this benefit of what Haddon calls the 10 technical strategies. And I'll go through a couple of these. Again, this is a conceptual model to think of the range of options. We'd all love to prevent a hazard from existing in the first place. I'll say we've got a firearm problem in this country. I don't think we're going to uncreate firearms or change that policy of how firearms happen. So what do we have any other choices than on or off, exist or don't exist? What the Haddon strategies show us is you do have a range. And we'll start at the top, and I'll go through a couple of these. Stop a poisonous, this is the example of this, prevent the creation of a hazard, and the example is stop a poisonous agent from being created. Well, that's good, and sometimes that can happen. But what happens if it gets out in the environment? Well, how about if we can reduce the amount of that hazards that's released? A classic example of that is don't put a lethal dose of poison in a pill jar. Don't dispense lethal doses. So break up the hazard so it maybe won't kill an individual or a population. Prevent the hazards release that already exists. So in other words, this example is bathtubs are really slippery. That hazard's out there. We'll put skid-resistant strips in a bathtub. So I won't go through all of these, but you can look at your own time, and you can look on the internet, and there's lots of great examples of how the Haddon strategies have been applied. I'll pick a couple others out. Pedestrian walking is really hazardous if you walk on the freeway. So separate the hazard of the freeway from the population that you're trying to protect. So separate sidewalks from hazardous roads. I'm sure the boating field has addressed this to some degrees, separating the type of watercraft in a really busy channel or something like that. And then this goes all the way down to rehabilitation. You know, if an individual is going to be exposed to hazards, I certainly wouldn't step onto an NFL field and try to play football because my body is not in condition to do that. But part of the strategy is get the body conditioned. We wouldn't want swimmers of different abilities to all go in the same body of water and sort it out. We separate them by ability and, you know, kind of prepare them for the hazard that they'll be exposed to. And then the final element in this is stabilize and repair the damage that occurs. And that's through good medical care, treatment, and therapy. So that is what I call the prevention spectrum. This is I found this on the internet to just use an example of how a coalition had thought through water safety. And as I said earlier, public health, the way we look at it is we try to look at the range of options. We don't try to say there's only one way to solve a problem. Every certain circumstance that you come up against, the best option may not be feasible to implement through politics, through financing. Maybe the community isn't ready to deal with it. So start somewhere, and this is an example of how this is in Seattle, Washington, through Seattle's Children's Hospital and Washington Department of Health example on the internet, where they looked at a boating safety or water safety issue and went through the pre-event, event, post-event, and looked at individual equipment, physical hazards, and social. I'm not advocating that this solves everyone's problem, but this offers an example of how a community coalition went and looked at water safety. Now, a couple other concepts in injury prevention that I'll offer up, that how we categorize injuries and we look at injuries to subdivide them up. Now, I'm shifting away from intervention identification. So the injury field looks at injuries from intent, intentional and unintentional. Intentional are classically defined as like assault, homicide, rape, suicide, self-harm, that the individual is harming themselves, so it's not necessarily an external device, although suicide can be achieved with a firearm or with a handgun. But the idea that the strategies move closer to an individual because of self-harm, or unintentional. And I'll give examples of how the world is divided up. In looking at injury data, it's helpful to understand where boating safety is categorized, and you'll see in a couple slides, there's many, many subcategorizations and divisions of boating data. But in general, the injury world divides by intentional and unintentional. And then in the coding of data, what I'll get to in a moment, the broad coding of data is basically lumped by the activity that the person is doing. So boating safety falls broadly within the transportation injury field, also with air transportation, train transportation, automobile transportation. While the transportation is very different, the key element, it's the energy. You're on a body, a device that's moving. So the energy is resulting from the moving body, whether it's a train, an airplane, or a boat. And so the strategies are that thing is going to move. So if you can't control the movement of that thing, provide protective equipment within that vehicle. That's the broad concept of boating fitting within transportation safety. The other broad categorization is what was the activity going on that when the injury occurred. And the final point, this is Della Penna editorializing, because I found this concept to be helpful, that a lot of injuries are associated with products, whether consumer products or industrial products. And most products aren't designed to hurt people. They're designed to do something. And it's always tricky because reducing the injury hazard in a product involves regulation, law, and in our country we're in this equilibrium that we have to work through of the free market forces or protecting an individual from an extreme hazard of a product. I don't think we're often in the boat or in the arena of trying to eliminate a product because of its inherent hazard, but that pitches the injury in the public health field often into that arena of free market forces and people wanting to make money for their product, which is a good thing. But adding a safety component onto that reduces the hazard while folks can make their money and sell their products, and people enjoy the products and live a very healthy and productive life. So I pulled off the internet just a couple examples here. ATVs is an example. A lot has been done with all-terrain vehicles over the years. We don't see three-wheeled ones anymore. It's four-wheeled. We struggle now with the age for the use of an ATV because about 90% of the people killed on an ATV are using one that's designed for a different age group. Small kids use an adult size, or adults using them on paved roads. That's just an example. So to try to work through that regulatory minefield to try to address a product. In this example here, this man's, I pulled it off the internet. Some of you on the call may know this image or not. It says, boats are for fun. They're not toys. And, sometimes these products are sold for the fun, and the hazard of using a product isn't really the lead line. It's a diminished line in there because we sell things because they're fun. And the final one, I'm no expert on the duck boat situation, but some products are used in ways that are inherently hazardous and dangerous. And so I will editorialize and say the stuff I've seen about the duck boats really makes you scratch your head and go, if we pass the point in time where this product's use is no longer good. So that's the range of options in there. In our country, what we settle on is if we can't figure out a way to regulate the product, we pass it on to the lawyers and the lawsuits, and then we get those warning labels on everything. And that's where injury prevention in its best realm tries to utilize data to identify the specific hazards of a problem and then work in the policy arena in a collaborative fashion to reduce the hazard of the product. I'm shifting into the data realm a little bit now. So I mentioned in that slide before that boating falls within that transportation realm. I'm only going to show a couple of examples here because it might help understand how to approach a data set. So this is the older classification system. This is called ICD-9, the International Classification of Diseases. This older data sets at 5 years old or older, that's how they're organized. I'm showing you both systems, the 9 and the 10, because they're not drastically different. Just the 10 offers more options for coding. So if you wanted to read through this on your own time, you'd say, 800 to 838 is water transportation accidents. And then there's another one down here. I lost sight of it. I had it on my sample one. There's drowning ones, but here it is. 910 to 915 is submersion, drowning, and suffocation. But you look through basically all of the energy causes of injury. Transportation is grouped at the top. Poisoning, surgical misadventures, fall injuries, fire injuries, environmental, which would be a blizzard or a snowstorm, and then the other categorized. So the next slide kind of drills into that 830 to 838. So the broad categories are watercraft causing submersion, and then you get multiple choices past the decimal point. Why am I showing this? Because when you look at an injury data set, it's kind of overwhelming to look at all the coding options. This is the World Health Organization's International Classification of Diseases. So any public health data, death certificate data, hospital data, outpatient data, it will be for the external cause of injury, we'll group data in this perspective. You can go on the CDC's Whiskers website, and you can pull out for any state. You can get the death data, and you can drill and show me all the water deaths in my state, and then it will group them in this numerical category for the older set. So I'm showing this as an example of how the world has settled on how to categorize injury data. Now, this is the external cause under the old system. There's also a diagnostic cause, which is like a broken arm. Well, you can get a broken arm from a fall, a fight, and so forth. So that's the distinction that I'm trying to draw here. So, as I said, there was also drowning. So drownings are covered slightly differently. You can drown in a bathtub. You can drown in non-boating arenas. You also have suffocation. So this is an example of how if you don't find it in the boating arena, you might find it in the drowning because there's options for coding. So this is the new system, and I'm only pointing out the new system because any data from about 3 years old or sooner will follow this system. Why I think it's helpful for folks who aren't public health to be familiar that, oh, this is how health people code the data, is if you're trying to collect data and mesh it with the health data isn't going to match if you're using a different way of thinking about how the injury occurs. So it informs if you're going to collect data, oh, well, how the health people look at it, because then maybe I can get my body of water, the injuries that come out of it, to match up with a national or statewide data set of injury. So this first screen isn't drastically different than the previous one. I've highlighted here already. You're still within the body of transportation. You still have water transportation injuries in here and drowning injuries separate. And I didn't even attempt to try to put all the subcategorizations, because in the new system that'll be around for 20 years or more, instead of a dozen options of subdividing up how that boating injury occurred, there's probably a couple hundred. The new data system has numerous subdivisions, which is really, really powerful to have the ability to drill down that far. But the downside of it is, are people who code the data able to drill down that far to code it? So I will hopefully stop talking about coding data. I only have a couple of minutes left, so I'll transition to my last couple points here on how the injury world looks at data or looks at interventions. Severity, burden, and targeting prevention efforts. That's the theme right here. So injury basically tries to target what's causing the greatest burden to a population versus the most number of injuries. You can have a lot of events, but it's the events that cause death, paraplegia, long-term disability, high hospital costs. How injury looks at it, if we can we use the iceberg concept. If we can hit the tip of the iceberg, we're reducing the burden on society. It may not be feasible to reduce all events that occur, and because of a lot of activities of life, minor injuries might occur. But it's unreasonable, I think most people would say it's unreasonable to expect participating in a recreational activity will result in a lifetime of brain injury or disability. So severity and burden on society is often how injury targets, especially when you look at a lot of data. How do you sort through a massive amount of data to drill down on what's the most important thing? Again, we try to focus to sort things out by severity and burden, targeting what's causing the most harmful events versus the biggest hazards. In every injury type, that burden might change. Drowning is a particularly difficult and tragic disease or condition if it's a near drowning and someone survives. And I dealt with this early in my career in pool drownings, where survivors linger in a very low brain functioning state for years and years and years. That's a high burden, and it's a really difficult thing to address. But each injury type, the burden might change as you approach it. So the final couple thoughts that I'll share is when we approach an injury, when we approach developing an intervention, so you go through your Haddon Matrix and you go through all your range of options, we like to say that a combined effect in addressing an intervention, a prevention strategy, is better than an individual effect. So say we want to get more people to wear seat belts. Only so many people wear seat belts solely based on an education campaign. Everybody's bombarded with education all of their life. I know I should have more money for college savings and retirement. I know I should do this. Education alone to avoid a hazard has a limited impact. What we say is a combined effect, and this little model off to the side is one of many models in injury that we use to say the power is combining education with a change. For example, in motor vehicles, we educated for about 20 years you should wear a seat belt, and then we passed laws. That was the environmental change. It was the policy change to require seat belts to use at a low fine level. Then we combined the law change with an enforcement approach. If enforcement never happens, folks ignore the education and they ignore the environmental change. So you've got to work all of these combined approaches together beyond just the general pass a law but don't do any education and don't do any enforcement, or just do enforcement without educating folks that enforcement is happening. It's the combined approach that we advocate for. We found it's not that one of these alone won't work, it's the combined effect will have a much greater effect. And then I drill down a little bit deeper and I go, it's really important from my perspective to use data to establish a clear understanding of the issue. The more specific you can get, the better chances are you're going to have an intervention that's successful. Who's at risk based on the data? What's the root cause informed by host, agent, environment factors? What needs to change and what can be changed? What needs to change is different than what you can change. I haven't found the ability to change the weather, but you can, during the time where the highest population is exposed to the risk, make a change there. Sometimes there isn't a political will to do what needs to be changed the most, so pick something that can be changed. What specific change needs to be made to address the problem, and who needs to be involved? That's why I advocate for a coalition approach. Use data to identify the problem you're trying to address, identify the change you want to make, design your change, and evaluate your efforts. And the last thing I'll just leave with one slide after this is evaluation is essential. We often in public health, as we get more skilled, we start with evaluation. But my simple way of working with coalitions over the years is everybody has a little bit of time to work on something. And I often say you want to spend the time doing something that has the greatest opportunity to make an impact. So you want to use your time effectively, and you want to be able to demonstrate to others that you made a difference. Evaluation is how you do that. It's how you decide, looking at other evaluated projects, well, this works and this doesn't work. And then it's a way to show your partners and your funders or your community that we made an impact and it made a difference. So the time that you spent or the political capital was a real good investment. So I end with evaluation, but I could have started with evaluation, but I wanted to kind of build up to that point. So my last slide is again, I started out by saying I don't consider myself anything at all involved as a boating safety expert, but I've put together here some of the things that I've seen in boating safety, categorized from how public health looks at it, that have made a great impact, and maybe starting points to think through, or just to recognize that y'all are doing a lot of really good work already, and maybe you can advance your work by combining some of these strategies. Human factors, PFDs and float coats. We have all kinds of water safety training out there that's really important and good. I certainly recognize that drunk driving is a problem on the road and drunk boating is a problem on the rivers and lakes. Enforcement strategies for those, boating design, safety features, boating in suitable conditions, safety inspections, and then in the environment, you know, having good charts, channel markers, and weather warning system. So I will end my comments there. I thank you for the time. Hopefully you've got a little look at the world and consider adding someone with that skill set to help think through what you all want to work on.
Thank you so much, Alan. That was great. I am now going to turn presentation over to Lieutenant Seth Wagner. And Seth, you are all set.
Thank you very much. Hello, everyone. Clear the screen here. And just following in on what Alan was speaking, I'm really just going to be talking about the data that we have available from a boating safety program side, and then, you know, posing those types of questions or whatever of where and what can we do, looking outside the box and applying the public health model approach in what we're already doing. And in many ways, you'll probably notice that we kind of already are doing some of those standards with some of our education outreach and regulation. So starting off, just big picture of recreational boating. We have over $121 billion in the industry, which is supporting approximately 650,000 jobs and close to 35,000 businesses. So there's a lot of partnerships and a lot of important members that can be brought into the picture of trying to increase boating safety. There's an estimated $36 billion spent just in 2016 for purchasing of boats, servicing, supplies, fuel, storage, all the gambit. So there's a lot of monetary interest there as well. Approximately 95% of the boats in the U.S. are less than 26 feet in length. You'll notice that this is kind of important as we start drilling down into more of the data side of things. We're just drilling further down in the big picture of it from 2017's U.S. Coast Guard accident statistics on recreational accidents. There were 4,291 accidents involving recreational boats. These accidents resulted in 658 fatalities, 2,629 injured persons, and approximately $46 million in damage. So from an injury outlook, you would actually combine the fatalities and injured persons, because that injury, you know, it would include a fatality. So just making sure everybody was following on the same page. Fatality rates decreased in 2017 from the previous year. We had a 6.8 decrease nationally. The number of injuries decreased just shy of 10%, and accidents overall decreased just shy of 4%, and that's nationally. 76% of fatalities in 2017 were the result of drownings. 84% of those drownings, the victim was reported as not wearing a personal flotation device. 8 out of every 10 boats that involved a drowning were less than 21 feet in length. So you'll see that correlation from where I was talking about the large number of boats that are purchased and used are under 26, and then that we have a very large proportion of those shorter or smaller vessels also being involved in fatal accidents. What do we know? Well, from all the boating accident reports and statistics that we've drilled down, alcohol is the leading known contributor in fatal boating accidents. It's also listed as a primary factor in 19% of deaths. 81% of fatalities occurred from vessels operated by a person with no formal boating safety education or instruction. Conversely, only 14% of fatalities occurred on vessels where the operator did receive some type of formal education, and it was more than likely nationally recognized. The top 5 contributors for your fatal accidents were operator inattention, operators no proper lookout, and operators inexperience with either the vessel, the environments, or the location, machinery failures, and alcohol or drug use by either the occupant or the operator. If you look further into the statistics of it, 41% of fatal accidents were from falls overboards. This has been the leading accident type for boating fatalities for many years. If you're familiar with boating safety in general, you'll know that your fall overboard accidents are not the big Hollywood style events that you would think of when somebody would say, oh, well, he fell overboard. It's not a big explosion or impact typically that causes that fall overboard. It's a simple event where it's one, maybe two people on board and somebody falls over, sometimes for known reasons. They're unstable where they're standing, or they step off the side of the boat to relieve themselves. Also includes a lot of small paddle craft, and they're inexperienced in use of them and they fall over. And a lot of those result in unknown environment hazards for that, because we obviously aren't able to interview that operator to know what the situation was and how that separation from the vessel occurred. In Florida, 52% of fatalities were drownings. Alcohol or drugs was a contributing factor in 24% of them. 90% of our victims are male. 73% of operators in fatal accidents were older than 36 years of age. And 74% of vessels in fatal accidents were less than 21 feet in length. So you can see that direct correlation nationally and with my lovely state of Florida. How do we know it? The plethora of recreational boating statistics that are out there. Most states collect their own information, and then we also assist the United States Coast Guard with reporting that recreational boating data into the BARD system, the Boating Accident Database. Each state has a requirement to make that reporting. How well that reporting occurs is also a piece to it as well. There we go. There's a wealth of data available from the recreational boating surveys, the BARD system I previously spoke about. States have some of their own systems for data collection. Law enforcement agencies may have some, and then of course in the educational arena has many studies and subjects where there'll be some data available. Additionally, NASBLA has created a RBS data available on their website with interactive dashboards that pulls all the statistics and such down from the Coast Guard's website. It's very informative to use and puts it in a good visual perspective. What are the gaps in boating accident injury information? Well, do we need more specific injury information? And like, what was the method of injury? We do collect that to a degree, but knowing a little bit more may help with education or outreach information. It might help with changing the regulation or manufacturing requirements of certain items if we can identify a specific thing that's happening more often than others. And then how do we apply that information once we've gotten it? What are the reporting rates? We all imagine that as a accident occurs and it involves either a fatality or a missing, we're all pretty believing that we've got almost 100% reporting on that. That typically somebody's calling EMS or 911 and getting help for those type of accidents because of their seriousness. And so in general, those accidents are getting reported. But it's believed that as the severity of the accident decreases, the option or apparent reporting of the accident will also decrease. So your simple accidents that may not cause a serious injury to someone, or at least known at that time, may not actually notify law enforcement or some other reporting authority that an accident occurred and just go seek treatment later when they realize that they're hurt. Ooh, too far. So with that, I'll add, you can apply the systems the way we are now. And I think if you're paying attention to what Alan had said earlier, a lot of our education and outreach efforts involve looking at the prevention of either the injury or the activity involved that creates that injury. I think an easy one to show for that from a manufacturing side would be looking at the improvement on flotation devices, specifically life jackets. A lot of manufacturers are now creating automated inflatable jackets that are much nicer to wear full time. So that helps with pushing the wear your life jacket all the time message. And then the fact that they auto inflate will, assist when they actually do enter the water and hopefully prevent that drowning. Those are some pretty innovative ways of trying to prevent drownings in general, especially since that's one of our largest fatality pieces. So I'll just add into that. That's about as much as I can put together with that. I'm more delved into pulling out specifics, so I will open the floor from there.
Okay, thank you, Seth. We'll now begin our question and answer session. You can enter questions at any time using the chat box in your webinar control panel to the right. And we'll give just a second to see if we have any questions come in. And my colleague, Julie.
We have quite a few questions already. So
okay.
I think we could jump right in if you're ready.
Go ahead, Julie. Sure.
Okay, so this question is directed to Alan. Is it possible to assist folks who enter in the ICD-10 codes to understand the importance of drilling down and entering in boating? And along those lines, can we suggest to the WHO, the WHO, some specific boating codes if it's not represented in the new coding? I know it's a stretch, but is it possible?
No. I don't want to be too facetious. I was involved in committees in the early 90s or mid 90s in the development of that code. It's been a long time coming to develop that code for the international consensus. So we at the state level, we deal with that a lot, that we think about things differently, but that's an international consensus document, and it took about 20 years to get implemented in our country. And, you know, they're moving on to ICD-11, which will probably take 20 years to get implemented in this country. So I hate to be so blunt about it and say that the options for changing the coding system aren't there. So it's more like, how do we work within the system? For those of us that have been working in injury a long time, I think we would say they've added so many more options between 9 and 10 that the challenge is, can we get folks to code, to drill the data down deep enough to pick up all those codes? Adding more codes and options is a blessing and a curse, because data quality drops off with a lot of different options. As far as assistance in helping learn that system, we're struggling, not struggling isn't the right word, we're kind of at the beginning phase of utilization of the data. What we rely on a lot is CDC has done some pre-packaging of data coding on whiskers. You can WISQARS, or just look up on the internet CDC injury data, and you can kind of get in there and play around with it. I should have pulled up how they packaged the boating data before this webinar. I didn't, so I don't know what has already been developed. I'll stop there.
Thanks, Alan. Yeah, thank you. That's really helpful. So an additional question is, and I think this could go either way, but should we now agree within our industry to change our language from referring to an accident to an incident?
I'll offer an injury prevention perspective. We try to be careful with the language, and we don't really call them motor vehicle accidents anymore. We call them motor vehicle crashes. You'll see on the news coverage sometimes that it changes, but I will say in the enforcement field, the law enforcement, and I'm guessing Seth comes a little bit more from that body, that's language of that system. And I would just say, my perspective from injury prevention, it's less important to me to get hung up on the terminology, to define common ground on how to address an issue. And I have earlier in my career spent too much time talking about the terminology of accident, crash, incident, which have missed opportunities to find common ground on solving problems. So I would say, yeah, have a conversation, but don't lose sight that you're really trying to save lives in the end. Seth, I don't know what your perspective on this is.
Well, and We've actually talked about that amongst other law enforcement professionals before, and I think in the end of the game, rather than spending a lot of time trying to educate everyone on what the meaning of incident and accident is, more so like what you were just referring to, in that understanding how we're applying it and just going forth with it from there, and just making sure that when we're referencing something that it's understood how we're referencing either accident or incident. For my part of the training for my officers in the state, we do use the term accident just because it's readily understood by specifically the general public and more so the boating public, to understand, because that's something that they hear often. When you say incident, then it kind of turns some people away as to what they're thinking about, especially when you're looking at it from a law enforcement's perspective, because then they're going to think that, oh, I may have done something wrong, and now I'm opening myself up to either criminal or financial, ruin for something. So it really is one of those things that changing the term, would it really help to expend energy on it, or is it better to just well define what you're referring to when you're using that subject?
Let me offer one other thought. Seth and I just met each other in the webinar, so I don't have anything to argue with you about. The motor vehicle field has adopted crash in a lot of cases. So crash is a more action-oriented word than incident. The problem with accident and incident is it takes you away from thinking about how to prevent it. It moves away. So I will not be argumentative and say try crash or collision instead of incident. But as long as the field recognizes that when you say accident, that sometimes it implies there wasn't anything that could have been done about it. When somebody's drunk behind the wheel, there's something that could have been done about it, and so forth and so. If they weren't wearing a PFD, there's something that could have been done. So the field will say, you're kind of letting someone off the hook that way. But no arguments from me. I understand the turf. You got a lot of folks that are working on this.
Thank you both. I really enjoyed your responses to that. So we did have another question here, and this is specifically for Seth. And it says, how do we know the person who died took a boating safety course or was a good swimmer? Where and how do we collect that data?
Oftentimes, the investigating officer or investigator was going to reach out to a family member who would hopefully have that information or knowledge. In my state, we have a database for those who have taken the course, so we can actually look and reference that to see if they've had the education course. Swimming ability is kind of up to interpretation. Are you swimming at a rate where you can kind of save yourself, but maybe not someone else, or are you a proficient swimmer? So those kind of things you kind of have to take, with a grain of salt when it comes to reporting. But in general, that's how we're getting that information, is usually from what we consider to be a reliable source.
Thank you. So the next question is, how does someone in a boating safety program gain access to the injury data that utilizes the IDC codes? I think ICD codes. I was like, wait.
I'll just, this is Alan. I can only offer up the CDC whisker data. Anybody can find online, and it does statewide data, and it's coded through the older data is not ICD-9, CM, clinical modifications. Newer data is ICD-10. Anybody looking at a decade-long data, when you transition from 9 to 10, you might see a change in the rates because of the changing in how the coding works. Seth, I don't honestly know if in your world, if you're using injury-coded data. I'm curious.
In reporting side, no. Statistics-wise, we're not reporting it in utilizing the ICD codes. It's very state dependent on who is entering the system or the data, especially into BARD. I don't think BARD would even be able or capable at this moment right now with adding that type of feature. But certain states and how their reporting authorities are set up, it may be multiple people entering boating accidents into a system, or it may just be one. So that would the training and such to make sure that we're getting quality data and quality entries would be a difficult task, I think.
Yeah, and I'll say, like, I can't speak for other states because everybody does it a little bit differently. In North Carolina, we have an injury epidemiology unit in our office. On our website, we post burden documents across the leading causes of injury, and we have the death data and emergency department data and so forth. I will say that I don't think we've done a burden document on boating safety per se. I think there is one we did a couple years ago on drowning, but each state would be slightly different. But one way, if you don't, for you on the call, go to CDC Whiskers and see what you can get for your state. The other is to look at your state injury program and see what their website offers data-wise.
Great, thank you. And that actually relates to another question that we had here, is that how do I find my state contact so I can get more data from the public health folks? Do you have any additional insights that you would want to provide?
Well, Julie, I go to the Safe States website, but I don't know if the general public can get the state-specific data, contact information. I don't know if that's a behind-the-wall kind of access, but honestly, when I want to find out who's in another state, I go to the Safe States site. The other way I do is I just internet search injury prevention Colorado, injury prevention Wisconsin, and just see what their public health agency pops up. That's the beauty of the internet. You can kind of cut through a lot of it quickly. That's the only centralized spot I know.
Thanks, Alan. Yes, I was going to say our member directory is available to members, but you can access a lot of contacts through our website. But I would even say, like you mentioned, just Google your state health department, and then most of them I have found have an injury kind of a sub page somewhere within their state health department page that you can then kind of funnel your results.
One more thing I'll add, because I know a lot of folks on the call aren't as familiar with the public health world. Our federal agency that kind of dominates what we think about is CDC. So I always say to folks, go see what's on the CDC site, Communicable Disease Center, because they're sort of the public health data source and they're our guide up above also. And you can often find good data information and general contact stuff there.
Great, and I'm actually pasting a link in the chat box here to our website where we do have links to all state IVP programs. So if you want to take a shortcut and go to the Safe States website, whether they're members or not, it at least gets you to their webpage. So you'll have to still do a little digging to find the specific contact at the agency, but it'll at least get you to their webpage.
Julie, did you write that question in there?
I did not. It almost seems like I did, but it was not me. So we do still have a couple more questions that I can ask. Looks like we still have plenty of time. So the next question is, trauma coordinators, one at every hospital in my state, are trying to put together life jacket loaner stations for each public body of water. Who would be good partners to bring with us?
Seth, are you familiar with that program?
For the loaner program, yes, to a degree. It's typically grant funded. Any organizations that would like to participate, I think, would be welcome to at the table for that. Any of your youth organizations, any of your other safety programs, a lot of your manufacturers are more than willing to help in one way, form, or fashion, and to be included in that. We have a few set up in the state, and we were leaving it more for the local municipalities to work with and put up, because they are much more set up to kind of oversee the stands and those kind of things, and make sure that they're staying in good repair and such. But I think there's a wealth of organizations out there. You just got to understand to look outside of the small window of not just looking at boating safety organizations, but everyone that's involved within boating and safety and or education, along with manufacturers.
And I'll just add a North Carolina perspective that we are fortunate that we have a very robust and strong Safe Kids program that's within our state Department of Insurance, and both Department of Insurance and Safe Kids have done a lot of work over the years to help get loaner programs going. In our state, the Chief Fire Marshal's office is also within the Department of Insurance and Fire Services, because of the rescue component, had in our state had interest in this area also. So sometimes it's not the usual partners you think of, because not everybody thinks of those type of partners right away, but our state, they've done fantastic work.
Thanks, and I was about to chime in and mention Safe Kids based on experience that I've had working in Washington State, where we have lots of loaner board programs, and another a fellow attendee today also answered and said Safe Kids Worldwide, your IVP state person, the boating safety community, and you can also contact the Alaska Office of Boating Safety if you want to talk about the life jacket loaner boards. Also mentioned that Safe Kids Worldwide recently did a webinar on this very topic, so that might be a good place to look. We have some others chiming in, say make sure you bring on board the individual keepers of the land who have to manage them, whether that be state parks, county parks, federal parks. And I know in Washington's experience, in my experience, many of our Safe Kids coalitions have found good working relationships with volunteer organizations like Boy Scouts. Some have used it as their the word just left me, their Eagle Scout project, and they've built the boards, and they also partner a lot with the fire stations, and many of them will kind of adopt a board, and they're responsible for kind of the upkeep of it. They check on it, and then the Safe Kids person or injury prevention person just make sure to supply life jackets when needed, and that sort of thing. So.
Julie, just to chime in too, with my experience with Safe Kids, other organizations using the PFDs would be YMCA or Parks and Rec departments with their swimming pool programs. So kind of some good crossover there as well, and getting the education out.
And the only thing I'll add to that is don't always just lock yourself down to thinking of like loaner boards or stations. That subject reminded me a project that Alaska did where they issued or gave out life jackets to a lot of the smaller communities in the northern areas, that they actually gave the kids their specific life jackets, and they like them so much and take so much great care of them, and then they're able to trade them out for a bigger and better fitting model later on down the road. So just think outside the box when you're looking at loaner programs.
I'll just, I guess, give a plug for the next webinar. One of our attendees, I think, is maybe a presenter for the next in this series, and said that loaner programs will be discussed in much more depth at that time. So attend webinar 3 next week to hear more about loaner programs. And the final one that I have to, here still in the question panel is not really a question, but much more of a request for Alan and Seth, is asking if you would join or at least provide input to the NASBLA Passenger Safety Committee. So maybe something to think about, and you can touch base with Kelly Toth on that.
Well, thank you.
This time, that is all the questions. If we want to give it just a moment to see if anybody else has any questions. Otherwise, I think we might be wrapping up.
Sure. While we're doing that, I'm going to take the opportunity to thank everyone for participating in today's webinar. We hope that this was informative and helpful to your work, And we would like to thank our speakers, Alan Della Pena and Lieutenant Seth Wagner, for their wonderful and insightful presentation. This webinar will be available soon in the Safe States Training Center, as well as the NASBLA e-Learning Center. And following this webinar, you will be receiving an email with a link to an online evaluation. So we really appreciate the feedback and comments that you can provide to us as we plan future presentations. Julie, did we get anything more in at this time?
No, no more questions at this time.
Okay. With that, again, thank you everybody for participating, and at this time you may now disconnect.